Hello everyone, I am myself Dr. Rajesh Gubba. So in this particular session, I'll be doing a quick discussion of the quiz which I have posted on 29th of April on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So every day I'm posting the quiz questions on my Telegram channel, and subsequent day I'm giving the explanation of those questions. So please follow my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, for everyday quiz questions. So if you see the first question of that quiz, we have a 72-year-old gentleman with normal renal function and the serum sodium is 125 milliequivalents. He presents with new onset focal seizures. Which of the following is the best drug to manage the patient? The options are sodium valproate, carbamazepine, levetiracetam, pregabalin. So if you see the clinical scenario, the patient is having the focal seizures and the patient is having the hyponatremia. And for the focal epilepsy, the drugs which are used here are mainly the carbamazepine or carbazepine and the levetiracetam. But you have to understand that carbamazepine, it will induce the hyponatremia. And already the patient is having the serum sodium of 125 milliequivalents per liter. So that is the reason why carbamazepine is not an ideal choice of giving the drug for focal seizures in this clinical scenario whenever there is hyponatremia. So what would be the best answer here? It is levetiracetam, because levetiracetam, it is not associated with any of the hyponatremia. So that is the reason why the answer is the levetiracetam. Now moving on to the next question. Right. So the question is, when cerebral blood flow falls to less than 16 to 18 ml per 100 gram per minute, how long it will take for the brain infarction? 1 hour, 2 hours, 4 to 10 minutes, 1 minute. So you have to understand that if the cerebral blood flow completely falls to zero, then it will take 4 to 10 minutes for the development of the infarction. Whereas if the cerebral blood flow, if it is reduced to less than 16 to 18 ml per 100 grams tissue per minute, then the time required for the infarction is almost 1 hour. And if the cerebral blood flow, if it is reduced to less than 20 ml per 100 gram tissue per minute, then the brain will develop ischemia without infarction, until unless if that decreased cerebral blood flow, it is there for several hours or days. If the decreased blood flow is there for several hours or days, then the ischemia will turn into the infarction. So this particular slide is very, very important. So what is the question asked for us now? It is less than 16 to 18 ml per 100 grams per minute. So it will take almost 1 hour for the development of the brain infarction. And the next question is, patient is having impaired comprehension and naming but normal repetition and fluency. What is the probable diagnosis? The options are anterior transcortical aphasia, posterior transcortical aphasia, isolation aphasia. So now what are the problems in this patient? Only there is impaired comprehension and there is also impaired naming. But repetition is normal and as well as the fluency is also normal. So you come across this in patients with the posterior transcortical aphasia. Now let me show you all the forms of the aphasia. One of the very, very important clue in this patient is the impaired comprehension, and another important clue is the normal repetition. These two are the very, very important clues. First, let me tell you which all conditions you have the impaired comprehension. Now this particular slide is very, very important for diagnosing all the forms of aphasia. So if you take this, impaired comprehension is seen in Wernicke's aphasia, impaired comprehension is seen in global aphasia, impaired comprehension is seen in case of posterior transcortical aphasia and as well as the isolation aphasia. But what is given for us? The repetition of the individual is being preserved. So in which conditions among these four the repetition is being preserved? Which among the conditions the repetition is being preserved? That is the posterior transcortical aphasia. So among these four where the comprehension is being preserved, among these four where the comprehension is being impaired, the condition where the repetition is being preserved, is in case of the posterior transcortical aphasia. And in posterior transcortical aphasia, even the fluency is also preserved. So in posterior transcortical aphasia, now please remember, your repetition and fluency is preserved and your comprehension and naming, both of them are impaired. That is what is given in our clinical question also. Whereas in Wernicke's aphasia, everything is impaired, only the fluency is being preserved. Whereas in Broca's aphasia, everything is impaired, only the comprehension is being preserved. Whereas in global aphasia, everything is impaired in case of global aphasia. Whereas in conduction aphasia, your language and as well as naming both are impaired, whereas the comprehension and the fluency are being preserved in conduction aphasia. Whereas in anterior cortical aphasia, remember, comprehension and the repetition of the language is preserved, but your naming and as well as fluency is impaired. And posterior cortical aphasia, just now we have discussed. Whereas in isolation aphasia, just remember, the echolalia will be there. Remaining everything will be impaired. And in anomic aphasia, everything is preserved, but the naming is impaired in case of anomic aphasia. So this particular table is very, very important in determining what is the cause of the aphasia. So the answer in our question is the posterior cortical aphasia. And you see the next question, that is, a 46-year-old patient complaining of severe bursting headache on examination. He was found to be conscious but restless. There is neck stiffness, drooping of the right upper lid were observed. What is the clinical diagnosis? Cerebral embolism, posterior communicating artery aneurysm with subarachnoid hemorrhage, anterior communicating artery aneurysm with subarachnoid hemorrhage, cavernous sinus thrombosis. So here, very, very important point is the severe bursting headache, right? So what is the clinical condition where you will have the severe bursting headache? That is in case of the subarachnoid hemorrhage. So that particular symptomatology of severe bursting headache will make us to narrow down the number of options. So the answer should be either B or C. Now the other points which tells that it is subarachnoid hemorrhage is the patient is having neck stiffness also. So differential diagnosis for neck stiffness is meningitis and subarachnoid hemorrhage. But in meningitis you will have high grade fever, which is not there in our patient. So it is definitely subarachnoid hemorrhage. So the answer should be either B or C. Now another important finding which is being given here is the drooping of the right upper lid. So or drooping of the right eyelid. So in which conditions you will have the drooping of the right eyelid is, see, drooping is mainly because of the paralysis of the levator palpebrae superioris muscle. And the levator palpebrae superioris muscle, it is supplied by the third cranial nerve, that is oculomotor nerve. Now, if there is compression or if there is damage to the third cranial nerve, then there will be drooping of the right eyelid. Now, among these two vessels, between the posterior communicating artery and as well as anterior communicating artery, which vessel is in near to the third cranial nerve? It is the posterior communicating artery. So the posterior communicating artery aneurysm, it can cause the compression of the third nerve, causing the drooping of the right eyelid, and because of the subarachnoid hemorrhage, the patient has developed severe bursting headache and there is also the neck stiffness. And the last question in the discussion, we have a 70-year-old male coming with left-sided weakness of the body, right? Left-sided weakness of the body. Age is 70 years. And that left-sided weakness recovered completely within 18 hours. On examination, the blood pressure was 150 by 80. Patient is known case of hypertension and diabetes mellitus. What is the ABCD2 score for this patient? The options are 7, 4, 2, 6. Now, you take this ABCD2 scoring system. What is the importance of this scoring? The importance of scoring this particular score is, this particular score will tell you the risk of development of stroke following transient ischemic attack. Now, let us try to discuss this ABCD2 scoring system. So, if you take this A stands for age of the individual more than or equal to 60 years. So what is our patient's age? 70 years. So give a score of 1. And B stands for blood pressure. Systolic blood pressure more than 140 or diastolic blood pressure more than 90. What is the systolic blood pressure of our patient? That is 150. So give a score of 1, right? And C stands for the clinical symptoms, that is unilateral weakness or the speech disturbance. So if there is unilateral weakness, give a score of 2. So if you see our patient is having the unilateral weakness, right? And which side weakness? That is left side weakness is there. So left side weakness is there. So give a score of 2, right? Give a score of 2, okay? And D stands for duration, more than 60 minutes, give a score of 2, and 10 to 59 minutes, then give a score of 1. See, our patient is having the weakness for nearly around 18 hours. That means the score that you have to give is 2 again, right? And if diabetes is there, give another score of 1. So our patient is a diabetic patient. So that is the reason why give another 0.1. So if you calculate the total score, how much is this? This is around 7. So if the score is 7, what is the chance of development of 3-month rate of stroke? The chance is almost 22%. So what is the ABCD2 scoring system in our patient? It is 7. Okay, so these are the discussion of, this is the discussion of the questions of the quiz which is being posted on 29th of April on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So you can follow my Telegram channel for daily quiz discussions, and you can follow my Instagram handle, that is Rajesh Gubba, for daily updates related to general medicine. Thank you very much. See you tomorrow again.